Everyone. I'm really excited to be back this week. I am going to go ahead and share my screen. We'll have a PowerPoint again just to kind of structure our time together. My hope is that this training in the next 2 hours, we'll spend some time together talking about the intersection of sexual trauma and eating disorders, and that you'll leave with, my hope is, information generally about eating disorders, and then information about, as you're working with someone who's presenting with a history of trauma and some disordered eating concerns. Like I shared last week, please make yourself comfortable. If you would prefer to have your video off, turn your video off. If you prefer to have your video on, by all means. Recognizing that this can be a sensitive area, feel free to leave and come back as you need to. And my hope is there will be time kind of throughout the presentation that I'll be asking for your thoughts and questions that you might have. And I want this to be dynamic, so at any point, feel free to unmute yourself and ask a question or type a question in the chat box. So I'm going to share my screen. I'm using a different monitor than last week, so just bear with me while I figure out the tech part. Where? Can everyone see the PowerPoint slide? Okay. And it looks like today I will be able to see the chat as well. So I'll try to check in periodically with that. So just a brief overview of what we'll be talking about today. The first part of the presentation today is going to be primarily focused on eating disorders, disordered eating, separate from trauma, just some basic information on things to look for and things to assess. And then we'll transition to talking about the relationship between sexual trauma and eating disorder presentations and things to keep in mind. We'll also go over some proposed etiological pathways, so hypotheses about why eating disorder behaviors might be exasperated or might start following a sexual trauma as a way of coping. And that you'll see a lot of if you were here last week, a lot of that will go back to establishing safety just in a maladaptive way. And then I'll present a case that I worked with, and we'll kind of go together through the clinical intake and some treatment considerations and what happened in our work with that. So again, there will be points during the presentation that I'll ask for questions or pause. And I just invite you to, engage in conversation. Feel free to pause me at any moment. So before we begin on the topic of eating disorders, I think it's really important to recognize that everyone has a body. It's a universal truth, and that means that we all have our own relationship with our body, and that body image is a multidimensional, dynamic relationship, and that we also have our own experiences with eating and messages from family and important loved ones about food and body and worth. And we're also then kind of living in a snow globe and inundated with messages around what it means to be healthy, wellness, fitness, dieting, and that there are a lot of pervasive unhealthy norms. So it can be really hard to even think about, like, what does establishing a healthy relationship with food look like? And so wanting to recognize that, and that it reminds me a bit of the fish in the water analogy, that we're all fish in this water, and the water is very much messages around body and worth and eating. And it can be very hard to realize how inundated we are with those messages if we're not out of the water. And this is something that can be really hard to step away and out of the water. I think there's been a lot of positive movement in anti-diet culture, health at every size, and body positivity in the last few years. And just recognizing that because we don't come into the room with a blank slate and we come in with our own experiences, it's also important to recognize your own internalized messages, assumptions, and biases around this topic, just like it would be with any other identity variable. I'll be referencing some research today, and I think it's just important to also highlight in this area with eating disorders, there's significant gaps in the research. So clinically, anecdotally, we know that eating disorders do not discriminate by race, gender, socioeconomic status, and the reality is a lot of the research is done on cisgendered white women, and there's just many populations that are sorely underrepresented in the research, and that's going to impact, I think that has impacted treatment and considering cultural variables and family messages, and even being able to accurately diagnose and make sure that person is getting the correct treatment. And so before we begin, I want to invite you to either unmute if you're comfortable unmuting, and then you can also use the chat box. But I just want to get a pulse on how people feel when working with disordered eating or eating disorders. And so if you don't mind sharing a word or a phrase that describes how you feel when you either see eating and body image concerns indicated on the paperwork, or you see that that's going to be something that's going to be present in your clinical work with a client. So I'm seeing intimidated, excited, control, thinking about trauma, unsure, anxiety, unqualified, not my favorite, uncertain. I think these are all really common reactions and common feelings walking in. It can be a really hard presenting concern to work with. And so just validating that. And I at least know, like, from my own kind of training experience, having to really seek out training or supervisors who felt comfortable in supervising that presenting concern. And so my hope is that leaving this presentation, you'll feel a bit more confident in assessment and just validating that this is a hard concern to work with. So the next two questions you can either feel free to reflect on your own, or if you want to use that chat box again, feel free to. But curious as a clinician, what you feel most challenged by when a client presents with eating and body image concerns. Safety concerns, yeah. I think especially with eating disorders, you know, there's the safety concerns, you know, assessing suicide risk, just recognizing that 1 in 5 deaths from an individual suffering with anorexia is suicide. And then there's also the medical safety concerns, and that can be really scary to work with. Yeah. Resources as well. I think it can be really hard to find providers, medical providers, dietitians who are specialized in working with eating disorders, being able to combat the negative thoughts, appropriate responses by support systems. Yeah. Thank you for sharing. So this may be similar, or things may change a bit. I'm just curious what you feel most challenged by when you think about the comorbidity of a person presenting with eating, body image concerns, and has a history of trauma. Just want to, yeah, what Karen is sharing about can't give up on food, it's learning how to live with the challenges. That's a very true point. I expect it. Yes, there can be strong correlations between trauma and eating. Where to focus on, what takes priority, I think that's very common. And then for this last question, this is just for you to reflect on. You can kind of keep it in mind as you go through the presentation, or even as you leave this space this afternoon. But recognizing that we do have our own relationships with our bodies and eating. How do you balance your personal relationship with your own body and eating and internalize messages, beliefs, and norms when you're in the room with the client? And that may be something you don't have the answer to today, and that is perfectly okay. So I'm not going to spend a whole lot of time on the details of the DSM-5 diagnoses, because that's not the focus of today's training, but I do want to highlight a few pieces here. So these are the feeding and eating disorders that you will find in the DSM. Some recent statistics that NEDA put out this year during Eating Disorder Awareness Week. Anorexia nervosa is the third most common chronic condition among adolescents after asthma and obesity. Binge eating disorder is very common. So statistics indicate that 3% of American adults are going to suffer and struggle with this disorder during their lifetime. And that more than 30 million people in the US will suffer from an eating disorder during their lifetime. I think what's important to note is I think while the statistics definitely indicate, the severity and seriousness and some prevalence, I think there's likely a lot of underreporting, and I would suggest that the numbers are likely much higher given difficulty in diagnosing. Sometimes there's just no assessment, and things can fly under the radar for a long time with physical health conditions kind of taking precedence or other things taking precedence. Common eating disorders that will correlate with a history of sexual trauma include anorexia nervosa with the binge purge subtype, bulimia nervosa, binge eating disorder, and avoidant restrictive food intake disorder, which is associated with food disturbance and disturbance in appetite characterized by more of a lack of interest in food or fear of aversive consequences from eating, or being kind of very sensitive to like the sensations of the food, so texture and other characteristics. So some of those aversive fears of consequences of eating may be related to fear of vomiting or fear of choking, fear of being full. But just to note that someone presenting with ARFID is not going to, it's unrelated to body image or weight concerns. I want to highlight OSFED. This in the DSM-4 was known as EDNOS. And this category just applies, this is a catch-all. This category applies to someone who is struggling with eating and it's impacting their quality of life and well-being. And they may check certain boxes in the DSM in other categories, but they're not checking all of them, so they can't make criteria. And so this kind of allows for diagnostic code and then, hopefully insurance coverage. There may be times where you specify kind of what you're seeing, if it's, bulimia nervosa with low frequency or purging disorder. But this allows for, I think it's most common that someone is never going to just fit like squarely in the boxes of a diagnosis of an eating disorder, which is why I often use the phrase disordered eating, because I think that captures kind of the relationship with food. And that doesn't mean that someone shouldn't be able to seek treatment. And this code can be helpful in helping someone get treatment without worrying about if they check certain boxes with the other criteria. Some other disordered eating concerns that are not in the DSM is orthorexia, which I'll be curious if this comes up as either a subtype under OSFED in the next rendition of the DSM-5 or as its own separate diagnostic code. But this is someone who has a hyper focus on health and wellness. So they have very rigid food rules around not eating certain things or exercise rules. And so it may not be that someone presents, with the purging behavior or weight changes, or even the same type of body image distortion that is characteristic of anorexia nervosa or bulimia nervosa, but a strong focus on health and wellness in a very unhealthy, rigid way. And then another one that, recognizing that I work at a college counseling center, and this is something that I've seen in the population that I'm working with, is something that's been coined drunkorexia, which is this idea that people are, that last one was called orthorexia. Let me see if I can. And then this next one that I've heard been coined is called drunkorexia, which is this behavior where someone may restrict all day for a variety of reasons, and then drink at night. So the motivation for that behavior might be to save money and get drunk quicker. It might be to save calories and have calories later, and then eat food that one might typically eat when intoxicated, and then purge easier. Either way, it's very medically dangerous. And so these two are not in the DSM, but can be assessed, with questions. This is just a perspective on the DSM-5. This is from a Hayes registered dietitian, Emily Murray. She has a practice in Nashville, I believe, and will work with clients remotely. She has a pretty strong social media presence in the anti-diet culture Hayes world. And so this is sometimes an account that I'll recommend a client to follow. But I think this is a really nice perspective on diagnosis and kind of the issues with the DSM-5 and eating disorders, which can be a barrier to seeking treatment. Just that it's flawed, outdated, and fat-phobic, that someone does not have to meet criteria or check boxes for a certain eating disorder to seek help, and that the best time to seek help is the moment you are starting to feel a lower quality of life because of your relationship with food. Also recognizing that that can be a difficult perspective to apply when you're also working with insurance companies. And so just recognizing that individuals may move, like cross-diagnostic is very common. So individuals may move kind of through different disorders depending on life circumstances, time, and a variety of stressors. I think this captures kind of the vicious cycle of disordered eating and how someone may be engaged. If they're restricting in kind of in this top right area, or if they're in this, very active cycle. But the idea is that, and I think a lot of the pervasive unhealthy norms that are in society very much promote this binge restrict cycle. And the idea is that restriction can look a variety of different ways. And I think it's commonly only talked about with, low calorie intake or a calorie deficit. But the reality is our body's main purpose is to have us survive. And so restriction can be delaying eating. So going more than 5 or 6 hours without food, our body is going to be on alert for when that next meal is coming. Restriction can be more a cognitive restriction. So someone is following very, very rigid food rules, or maybe perhaps in action, they're not following food rules all the time, but those food rules in their head are really kind of dictating most of the time. So it's going to set somebody up to feel in that deficit. It's going to be not eating enough at meals or snack time. So kind of eating, I think my grandmother was often described as eating like a bird. So she would eat, but it was very not enough. And so if you were to look at her total day, it would be under what would be expected. And then also not eating, like only eating certain foods. So if you eat the same foods every day and follow these very rigid rules, at some point, our body's going to want something else. And, food is both fuel, but there's also food for the soul. And it's very much a, central part of how we socially connect. So if someone restricts, naturally, there's going to be cravings, especially if you're telling yourself that you can't do something. You're going to want to do something. Even if you think about telling a kid or child, like, you can't do that, they're going to be really curious and interested in thinking about like how to do that. And then the binge happens, and which is followed by, immense feelings of guilt. There may be a purging behavior that happens after this. And then the restriction cycle will start again. So someone who comes in and is very concerned and distressed about their binge eating behavior, my primary focus is actually going to be on decreasing the restriction. And that's going to be very counterintuitive and distressing to the person that I'm working with. But the idea is that the best way to interrupt the physiological triggers for binging is to make sure that someone is adequately fueling. I'm going to move the chat box here so I can see it. And then the other piece about eating disorders that was mentioned earlier about some of the safety concerns and the uncertainty, and I think the feeling unqualified or unsure, is the significant physical health and medical complications that can ensue. Just recognizing that a malnourished body leads to a malnourished brain. And that doesn't necessarily mean that someone has to be at, I think the stereotypical 90s viewpoint of emaciated, that every body has its own individual expected body weight and set point that is very much individually determined by their own height and growth chart, their genetics, age. And so someone can be malnourished and living in a larger body, and they're going to have physical health and medical complications, or be at risk for physical health and medical complications. And so really challenging the stereotype that you can tell by looking at someone that someone has an eating disorder. That's not true. So I think the other tricky part in working with eating disorders, because of the physical health and medical complications, it's imperative, ethical, and sometimes impossible to find an interdisciplinary team or a physician or a dietitian that you can refer a client to because of the lack of resources. And so I often recommend someone to, go to their primary care physician for some blood work, just to make sure that they're medically stable to continue as outpatient. I'll ask women that I'm meeting with if kind of what their menstrual cycle looks like, which can be tricky to assess with birth control and kind of the impact on the period there. It's common for someone with an eating disorder to experience significant GI distress, bloating, constipation, nausea, which can be really difficult and a further trigger for kind of distorted body image. And then, as I mentioned, the malnourished body leads to a malnourished brain. And so recognizing that, concentration, focus, memory, all of these things are impacted. And our brain is primarily made up of fat, and our myelin sheath, which, allows the kind of messages to go back and forth between the brain and the body and the central nervous system, is also made up of fat. And so if someone comes in malnourished, there can be times where someone can present as, slower processing, may struggle to engage. And that can be a symptom of this. The other thing that I think is important to note here is just dehydration and how this goes along with electrolyte imbalance. And so something that I'll also assess for is kind of what a person's fluid intake looks like during the day. And we'll talk a little bit more about that later. So before jumping to looking at the relationship between trauma and eating disorders, just want to pause and see if there are any questions, reflections, things that I need to clarify or spend a little bit more time on. I'll give people a minute or so with the chat box, and if not, we can continue on. I guess I have a question for you all. As a CSB, how does is insurance and utilizing the DSM-5 something that's necessary for providing care?
Yes, absolutely.
Okay. That's what I assumed and wanted to just make sure that assumption.
To the point correct. That actually, when you're mentioning like the NOS with the eating disorders, I'm not sure if that would meet criteria or not. We actually just had a whole conversation with our billing department recently about the need for specifiers and adding details on our diagnoses.
That's really interesting. Thank you. So we'll transition to talk about kind of the relationship between trauma and eating disorders. Okay, thank you for sharing your experience with the DSM. So research has shown that, kind of not surprisingly, unfortunately, that experiencing a sexual trauma may increase an individual's risk in the development of an eating disorder, but research hasn't consistently shown a significant or causal relationship. And so the takeaway is that, not everybody with an eating disorder is going to have a history of trauma, and not everyone with a history of trauma is going to develop an eating disorder. And it's really important to assess. I think it can be very dynamic, depending on, life stressors changes, if someone is, choosing to engage in criminal proceedings or a Title IX investigation and stress increases, to have an ongoing assessment and kind of checking in with someone about appetite and daily physical activity and just daily physical functioning, I think is in best practice. As I mentioned, some research has shown that there is more of a relationship between specific eating disorder subtypes with sexual trauma. So it's been shown sexual trauma history has been shown to be higher in individuals with bulimic and binge eating symptoms than individuals with specifically anorexia restricting subtype. But that research has also shown that with the binge purge subtype of anorexia, an individual is more likely to have a history of sexual trauma. Research has also found that Black women are more likely, almost 1.3 times more likely to be obese if they endorsed a history of sexual trauma. And so, research has really hypothesized kind of the pathways of why, what are the contributing factors to developing eating disorder symptoms following a sexual trauma. Again, research hasn't found a strong temporal relationship, but some findings and some studies have suggested that. And that there's definitely that sexual trauma can be a non-direct risk factor for the development of an eating disorder. So there's two pathways that we're going to talk a little bit about today. The first one being body perception. So this idea that trauma negatively, not this idea, research shows this, and you'll probably clinically, anecdotally hear this as well. Trauma negatively impacts body image, view of self. There's an increase in shame and self-criticism. And so the body becomes a source of re-victimization or a weapon or a way to exert control. And as we think about the first stage of Herman's stages of recovery that we talked about last week, it's establishing safety. And so there's also this sense that exerting control over one's body through controlling eating or exercise is a change in one's body to protect oneself, either through weight gain, weight loss, or weight change. And so some research and qualitative interviews and clinically, weight gain can be a way to become unattractive to a perpetrator as a defense mechanism, and also as a way to be able to physically protect oneself. So to become bigger and more intimidating and be able to, this idea that with this weight gain, I could prevent re-victimization. Weight loss, kind of some of the motivating factors there could be, with weight loss, there can be a loss of sexual maturity to this idea of becoming invisible, taking up less space as a way to, again, establish a sense of safety. Weight fluctuation, so it's very common in someone with bulimia nervosa or anorexia binge purge subtype to fluctuate weight, sometimes pretty rapidly depending on kind of hydration and number of binging and purging episodes per week. But weight fluctuation can be seen as an attempt to not be in the same body when the trauma occurred. And so that's creating some mental and kind of physical distance from the traumatic event. And so as you can see, really either of these are ways of establishing that physical, mental, emotional, as well as relational safety. And Let me just move this here. And sorry, just want to move the chat box. There we go. So it can be a way of establishing safety. I think we can all recognize and acknowledge that it's not a healthy way to establish safety and can cause more harm. But also recognizing that someone's doing the best that they can do to feel safe, and that it can also be, on the inverse, a way of self-punishment to manage that shame. So restriction can be a form of a way to self-soothe and reduce anxiety. It can also be a form of kind of matching that rejection and destruction and violation. So sometimes I'll assess the eating disorder behavior is when I assess for suicidal ideation or non-suicidal self-injurious behaviors. If I know that someone is restricting or purging, I'll wonder with them if they consider it a self-harming behavior, if they are severely restricting, what is their end goal? Is their hope to die by starvation? Do they have a sense of what's happening to their body in starvation mode? And then are there times where perhaps it's more of that self-soothing, numbing out, I don't have to think about what's going on function. So recognizing that it can be both a self-harm behavior and a way to self-soothe. And so some of that work might be with the client kind of recognizing and building awareness about the function and motivation with each behavior that they're engaging in, with the collaborative goal to decrease behavior, so that you're also working on kind of increasing more adaptive coping and self-soothing and self-regulation, so that they're not engaging in those behaviors. So these are two quotes from, I know that this is an old article, but I really it's a qualitative study and an interview with variety of survivors from different backgrounds. And I think these two quotes just really highlight how the body is viewed as a way to establish safety and changing the body. And so one participant noted that following the abuse, her and kind of listening to some of the messages from the family around body, she very much associated sex with flesh. And so her goal was to not be in the flesh and become invisible as a way to protect herself. And another participant shared that her goal was to, this is qualitative interviews with people who have been in recovery and have that insight and awareness. So I would be very surprised. So not to expect that this is something that's coming out at, an intake, but to look like the little kid that I was before the abuse began. Again, going back to a time where one felt safe and hadn't been violated. And so the second pathway that is considered is management of psychological difficulties. And I think this really speaks to, again, establishing safety. So there's this failure of the average expectable environment that's occurred. So recognizing that it's very common that there's a relationship between the perpetrator and survivor, and that there's been a failure of what one would reasonably expect from an environment, that trust has been violated, someone's body has been violated, and there's a desire to exert control over this environment that has failed them. And it can also be a way then, if I'm exerting control over this environment that's failed me, maybe then I can prevent it from happening again. And then there's, as I mentioned earlier, like strong emotion regulation pieces here. And so restricting, binging, and purging can all serve as a numbing mechanism. Some research has indicated that the process that happens when somebody is engaged in a binge and purge episode. So if you've ever sat with a client and assessed for binge eating behavior, typically someone will remark on feeling out of control, this loss of control, and then this element of an out of body experience. And someone may then describe, like, it can be a typical response of the purging as a way of kind of gaining back that control. And so there can be a parallel process between the dissociation that can occur during a trauma and the dissociation that can occur during a binge, and the purge can be a way to exert control back. Purging can also be a way of it could be self-destructive and self-harming. It could also be a way that the individual feels like they're cleansing or hitting reset and kind of getting rid of the shame that they feel very deeply inside as a way to make themselves feel more worthy or lovable. Though that moment of relief following a purge is often very fleeting, and the kind of crash and return to the shame and guilt that one feels, both associated with the trauma that occurred, as well as the guilt or shame that may be associated with the eating behavior that just occurred, is harsh, and can be that cycle can bring someone low very quickly. So I think it's also just important to note that ongoing assessment of risk is very important. Restriction can alleviate negative mood, and there's a couple different hypotheses about this. So there is a serotonin hypothesis about anorexia restricting subtype, where someone that kind of just recognizing the genetic components and the diathesis stress model, someone with high serotonin may restrict to kind of quiet their mind and quiet the environment around them. So if they're feeling overwhelmed, there's also kind of research that indicates that severe restriction physiologically is going to cause alexithymia, with the idea that emotional processing is not necessary for survival. So as you're thinking about kind of physiological needs needed that the body needs for survival, emotional processing isn't in that foundation. So it serves as a way to numb out and further disconnect from the body. Any questions before we move to kind of clinical intake and treatment considerations with the case? You can either feel free to unmute yourself or use the chat box. All right, well, I'm going to transition a bit here. I want to present a case example, and then I want to have us keep this case in mind as we go through some clinical intake and treatment considerations. And as we go through this latter part, I'll share more information about the case, and would love, to hear, if there are cases that you've worked with as well, feel free to share in the chat box. And so this client identifies as a 26-year-old white cisgendered woman. She currently is enrolled in graduate school. She was referred by a concerned professor due to weight loss. And she reported, the client reported, the professor did not report this. The client reported at intake, I'll share in a very vague way. She did not want to go she did not want to share much, understandably so, since I was a stranger at that point. She did report a history of sexually abusive romantic relationships that had, I was struck by the inherent power dynamics in these relationships due to age difference and occupation status. And with these relationships, the client really internalized the message that she alone is not enough, and shared that while she understands that the relationships were unhealthy, she really is still struggling with believing that she's deserving of better. These are some quotes that she shared. And she reported a pretty long-standing history of restrictive eating, and previously having engaged in a higher level of care. She felt pretty good about her engagement in the higher level of care, and at the point that we met, she reported being about 2 years in recovery, and so had relapsed, or had started to relapse with the onset of grad school. Is there anything from the information so far that I've shared that stands out to anybody, or from what I've shared, questions that you already have in your mind? Okay. And so the next part, I just want to have a conversation about how to ask and gather information. And so last week we talked a bit about the importance of, assessing for trauma and directly asking about, significant life events, traumatic experiences, times where that individual feared for their life, and acknowledging the responses that they were given, either on, initial paperwork that was filled out before, or, in session with the clinician. So similarly, I think it's really important to ask about appetite and exercise. And so I'll ask about, with every client, when I meet with them, I may not know what's bringing them in. I like to get a sense of their daily physical functioning, and if there's been any changes in the past 2 weeks. And kind of in that category, I'll assess for sleep and appetite, nicotine use, caffeine, and exercise, and ask, if there's any changes or concerns that individual is having. Depending on their answers to appetite or exercise, I may ask some additional questions. So I will, if someone shares with me that their appetite is quote unquote normal, and they don't have any concerns, I will follow up with, tell me how many meals, how many times a day are you eating? And if they have a history of an eating disorder or have ever struggled with their relationship with their body. And then if they tell me no at that point, I won't spend a significant amount of time. There won't be additional follow-up questions unless something is shared later, and I'll come back to that. So I guess I share that all with the idea that there's no pressure to ask all of these questions at intake, and that these might be questions that you come back to kind of throughout individual kind of counseling sessions as you gather more information. I think someone who may be presenting, I know from my experience, sometimes someone will present and there is a significant crisis happening, and that is priority. Something needs to be addressed, and it may not come out till later that there's also this underlying disordered eating behavior, or compulsive exercise that needs to be addressed. And we'll talk a little bit about how to prioritize what needs to take focus, but recognizing that sometimes even when directly assessing something, having a conversation about the importance of getting the full picture so that you can help them. And someone may not share at that moment, and that, if something comes out later, not to beat yourself up or think you should have known something, or if you had asked a different question. I think, trauma, the secrecy and shame and how the shame can really grow. Eating disorders love secrecy and want to isolate that individual so it can continue to flourish. And it can sometimes be kind of a dance to get information or to get a sense of what somebody might be dealing with. So with these questions, with that in mind, generally the goal is to assess for food, exercise, or body rules in a non-judgmental, non-shaming way. Look at really taking like a curiosity stance and asking more, even if like what you're hearing is I don't know. I'm sure you've all heard of interesting behavior when it comes to eating that makes sense for that person's disordered eating or eating disorder rules. And so just continuing to ask follow-up or more questions to clarify and get further details. And so these are some of the typical questions that I'll ask. I like to get a sense if somebody is reporting some level of distress around eating, if they are tracking their food. I think MyFitnessPal can be really detrimental to people with eating disorders, or even people who may be dieting, which can be a predictor of developing an eating disorder. Macros, which I think has really taken off in the wellness world, is just macronutrients, and we all need carbohydrates, protein, and fat. And so there's no, with that rapport established, I'll offer some, psychoeducation that I have, and there may be a time where, depending on what's being reported, referral to a dietitian is necessary, which can be really difficult to find because I think there is a significant lack of resources. I'll want to know if somebody is preparing their own food, if they're weighing their food, if they have any food allergies or food you avoid. If somebody ever finds themselves delaying eating by engaging in another behavior to feel full, like drinking water or tea or chewing gum or sucking on mints. I always ask directly if they've ever purged after eating, and then I'll follow up with being really clear about what purging is, so that can look like self-induced vomiting, laxative, diuretic use, or exercise following eating. If someone endorses purging, I'll ask follow-up questions to that, and I'll want to know how many times someone is purging. If they're self-inducing vomiting, I'll ask if, what apparatus they're using to self-induce vomiting. If it's fingers, a toothbrush, something else. And I'll acknowledge that similar to other things that we might assess at intake, this can be a pretty direct conversation that they likely haven't had outside of the room. I think it's really common for outside of the room for diet talk to happen and for comparisons to happen and things like that. But for someone to directly ask you what your eating behaviors are and to assess further can feel really awkward. And just to acknowledge that this is likely a conversation that hasn't happened outside the room, and that this is, highlights kind of the unique social contract that is a therapeutic relationship, that it is not the typical social relationship, that there are going to be questions that are asked that can be awkward and difficult, and to know that you're asking out of care and concern and the client's best interest, and that the more information you know, the better you are able to kind of assist in getting them the help that they need. I'll also assess fluid intake. because there can be some significant kind of medical complications that go with this. So I've worked with individuals who have a fear of water because of water weight, so that they will purposely not drink water and not drink fluid and dehydrate themselves. Which is very dangerous because water, like food, is something that we all need to survive. I've also worked with individuals who will drink copious amounts of water in a way that can also be have medical complications and be dangerous. And so really getting a sense of what their relationship is like with fluid, and how much water they're drinking or not drinking. I think for exercise, I like to ask how often someone, like what their general activity level looks like, just recognizing that someone doesn't need to have like a structured exercise routine to be physically active. If someone does report going to the gym, I want to ask about kind of how much time they're spending at the gym, the intensity that they're working out, how many times they're going per week, and then how many times are they going per day. And like food, if they track their activity on an app. I also like to get a sense of what their other activity during the day looks like. So are they going to the gym and then that's kind of it for the day? Or are they going to the gym and then also, you know, walking their primary mode of transportation? Are they someone who feels like they have to walk a certain amount each day on top of the activity that they're doing? Kind of, are they on their feet all day at their job as well? And things like that. Recognizing kind of that information is helpful. I think it's also really helpful to get a sense from the individual what happens when they're not able to exercise. Is there increased irritability, anxiety, not feeling safe in one's body? How do they feel when like their food rules are broken, either by a social event that happened or, you know, an unplanned thing that they hadn't planned for? Are they avoiding social events to avoid food? Are they canceling social events to spend more time exercising? Is their eating and exercise rules further isolating themselves? And I think this is just important to note because, you know, as we talked about last week, part of establishing safety, like that safety can't be established without connection and without social support. And so this can be, this is something that's important to assess. Generally, how isolated is somebody, and then how isolated is somebody based on kind of unhealthy coping behavior that they're engaging in with the attempt at establishing safety. I also like to get a sense as I'm having this conversation and I'll, you know, asking the individual if they have an understanding of how their behavior serves them, or does it feel like these are just very rigid rules that they have to follow, and all they know and understand at this moment is that if they don't follow them, it causes a lot of anxiety, a lot of irritability, and a lot of emotional dysregulation. And just to get a sense of kind of level of insight. Any questions or reflections so far? Are these questions that you ask at intake or at individual appointments?
So we are required to do what's called a daily living activities assessment, and one of the domains is nutrition. But I don't know that I ask about exercise thoroughly. I don't know that I explore all of this really thoroughly outside of the mandatory questions in the D20. So it's a good reminder of kind of considering some of these areas.
And I think too, recognizing that this is an ongoing assessment, And so as I shared last week that, intakes that I have with individuals coming in presenting with sexual trauma look different than typical intakes. And that intake is primarily about, gathering some important information, assessing kind of if medical attention is necessary for a SANE exam, and then really thinking about how are we going to establish safety in the here and now. And I might have on my radar, like, are they engaging in eating disorder behaviors? Do they have a history of an eating disorder? Is this something that they'll likely turn to feel safe? And it's not likely that all of these questions are going to be asked. And so just, again, giving yourself permission that it's an ongoing assessment. And so recognizing that it's an ongoing assessment, I think something else that can be really helpful to get a sense of is assessing body image. I think this can be something that's difficult to assess because it has you also perhaps thinking about like your own body image. And so just recognizing that to get a sense of how somebody views themselves, I like to get, I'll just ask them, like, in their mind, how much of their headspace is taken up each day by thoughts of eating, exercise, body image, or view of self. And typically someone who is in a pretty vicious cycle will share, that it's on their mind constantly. I like to get a sense of kind of body image and body image distortion. So asking like how they do view themselves. And, sometimes in my work with someone, I've described body image and the distortion that can come with eating disorders. And just with, non-DSM-5 disordered eating as, I don't, if any of you ever as a child went to like a circus and you walked through the part where there was the funhouse mirrors and maybe you were super tall in one and then super short in the other, and may have looked really distorted in another one. I imagine that the body image distortion is very much like someone's putting on glasses and viewing themselves in a funhouse mirror. And typically people, like that can be a helpful kind of analogy and a way to separate out or at least identify that sometimes the way that I view myself is not accurate. Like these glasses must be on. And getting a sense of when they are, how they do view themselves or how they do feel about their body generally throughout the day. Is it in one of those distorted funhouse mirror types way? Are they using words like gross or disgusting to describe themselves? If they are in a relationship or not in a relationship, but is their body image negatively impacting physical intimacy with a partner? Is their partner concerned, or is this caused tension in that relationship? I also think it's important to assess body checking behavior, and that can look a lot of different ways. So if they have access to a scale, is that something that they're using? How often are they using? Do they measure themselves? How often do they measure themselves? Again, not that you have to ask all of these questions, but kind of given the information that the client is sharing with you, these are perhaps some follow-up questions that can be helpful. I think the time spent in front of mirrors or reflective spaces can be helpful to assess, but also acknowledging that it's also really common for someone to be super body avoidant because of the discomfort and kind of distortion that they're feeling. And so it could be that someone is not spending any time in front of the mirror, and that's actually interfering with their ability to move about their daily life. And so part of your work might be kind of increasing time in front of the mirror and doing, you know, some exposure response prevention work in that way. You know, it could also be that someone who is body avoidant may present with more baggy clothing or kind of avoiding like sensory input on their skin as a way to increase comfort. They may not engage in body checking behavior in the ways that are listed here. So they may avoid the scale. And while the scale is typically something that I recommend to throw away and, you know, get rid of, that the weight isn't really an indicator of health or a full picture. There may be some benefit with some individuals that, like, it could be helpful to be able to go to the doctor at your physical annual and get on the scale and work with, you know, decreasing that negative response to the number and working in that way. So these are all long-term goals and just things to think about. The other thing that is important to assess is just weight trends. So if the person is weighing themselves or not weighing themselves, do they have a sense of if their weight has changed, you know, in the last 2 weeks or the last month? Have they gained a lot of weight? Have they rapidly lost weight? Is their weight fluctuating? And these are all perhaps indicators for a referral to a primary care physician for blood work, and also just making sure that everything is kind of medically stable, and also getting a sense of if they have an understanding of kind of how that behavior is serving them. Something that's come up more recently in the last few years is also just social media use. And so it can be helpful to assess how much time someone is spending on social media and then the impact that that's having on their mood or self-image. And if there are certain accounts that they're following that are really negatively impacting them. You know, sometimes I think it can be helpful to talk about just taking social media off your phone, but just recognizing that there's lots of ways that people use social media or staying in, you know, in contact with friends and family. There's also a list that I'll share of helpful social media accounts of dietitians or psychologists or mental health providers who are anti-diet culture and HAES certified, that can be a way to like increase some positive messaging throughout the week, recognizing that, you know, you may only be sitting with them once or twice a week. And so recognizing the relationship between food and family and trauma and family, I think it's really important to get kind of a rich picture of the home environment around messages with food, around events with food. And so these questions can sometimes provide some clarity about the function or service of the behavior in the now. And so wondering if food was withheld as punishment, were there consequences for not eating food, or was that family kind of members of the Clean Plate Club, dynamics around the family meal, if there was a family meal, if the parents or caregivers had their own really rigid eating or food rules that were, you know, kind of pushed onto the individual growing up. Was there fear of eating in public or in front of others? And then also getting a sense of financial security growing up, or insecurity and the impact that that may have had on food availability, scarcity, or just options in the house. And then also assessing for secondary trauma related to the eating disorder or experience as an eating disorder treatment. So if that person had, you know, experienced medical emergencies like a seizure related to their eating disorder, if they had negative interactions with former treatment providers, or if they were force-fed, you know, with a tube, just recognizing kind of how that parallels. It could parallel a former sexually traumatic event, and assessing kind of life events with the eating disorder in mind. So with the case that I mentioned, so I'll go back here. I can share a little bit more about some of the information that I gathered kind of in intake, but also just, as an ongoing assessment. So just as a reminder here, this is the information that I had at intake, and thinking about assessing appetite and exercise and trauma, knowing that she had some history of trauma and a history of restrictive eating, and that she was referred to me due to weight loss. And so assessing, what a typical day of eating looked like, getting information around that this individual only ate in social settings. So if there was like a reception or some luncheon related to her cohort, she would go and eat an appropriate amount, but then she would go a day, sometimes 2 days without eating. She reported being very body avoidant, and so that also showed up in not wanting to, that she wasn't currently tracking her food intake. She also recognizing that she previously had engaged in a higher level of care. Something that's common in eating disorder treatment at that higher level of care is very tracked food intake, to make sure that that person is getting the nutritional needs that they need to nourish their body. And so she had a very aversive reaction to the idea of tracking her food, and so was very avoidant of all numbers or tracking, not engaging in any body checking behaviors. She was someone who, part of something that was in my mind as we were working together is ways of increasing that connection with her body, so that she could sit with herself and eventually, get ready in front of the mirror for the day. She was someone who ate a lot of gum, or I guess she didn't swallow the gum, but chewed a lot of gum, and drank an appropriate amount of water. When we first started meeting together, she reported doing a significant amount of walking in the city, because that was her main mode of transportation. She didn't have a car, and also doing power yoga every day. And didn't like the idea of decreasing exercise. And as I shared, she was very body avoidant, was aware that she had lost some weight due to the way that her clothes were fitting. And she presented as undernourished in session. As I mentioned, she had a history of restrictive eating. She shared with me that it started before any sexually abusive encounters, and started more as a way to manage the tension in her household growing up. So she shared that dynamics around the family meal were pretty negative and tense. Her parents did not have, she described kind of the house as feeling pretty cold and very alone. She didn't have any specific memories of food rules being pushed on her, and felt actually like she was pretty flexible with the type of food. She just was not interested in taking care of herself. And that the message of kind of not feeling worthy, kind of being reinforced early on from just family dynamics, and then reinforced in subsequent romantic relationships, wasn't really interested in taking care of herself. and was able to, as kind of treatment went on, was able to identify that some of her eating disorder behavior was very, the intent was to be self-destructive because she didn't like herself. She hated herself. And so part of our work was kind of acknowledging kind of the bully that was like the self-destructive behavior. She also described her eating disorder. She would speak about her eating disorder very fondly. And so recognizing, that eating disorder behavior can be a way to establish safety. And for someone who is feeling isolated and alone, can become, I've heard an eating disorder described before as a dear friend, a security blanket. And so the idea of then letting go of a security blanket or saying goodbye to a dear friend can be that can be a grieving process. So our work, initially focused on establishing a regular eating schedule and really working on what was realistic and what was safe. And so recognizing that sometimes these are just 1 degree shifts. And so hearing her describe her eating disorder as her security blanket and wanting to establish therapeutic rapport, I don't want to step in and set an unrealistic goal of, eating 6 times a day when she hasn't been eating much at all, and be viewed as kind of this enemy coming in, taking away her dear friend. And so we spent some time, in that first session talking about what would be realistic, that it wasn't safe medically to go days without eating, and that for her to, continue with outpatient treatment, she needed to meet me somewhere in the middle. And so we agreed upon, that initial goal was just to try to have 3 eating events each day, spread out throughout the day, and increasing. This wasn't language that I used with her, but my kind of thought process was like the need to increase kind of calorie intake daily, and increasing nourishment for her. I will say that there was some buy-in for treatment because of her desire to continue with schooling and kind of the life that she had established outside of the eating disorder. And so also talking to her about, expressing concern for her level of activity each day, given how low her nourishment was each day. And so asking if she was willing to increase nourishment each day, increase fuel, and decrease some of that physical activity. And so we talked a bit about what felt realistic. And so recognizing that, there has been some research done about, yoga helping with that mind-body connection and being a really healing part of kind of that trauma process. I told her I wasn't opposed to a daily yoga practice, but wondered if she would be willing to do more restorative yoga practices, where so that practice is more sedentary and holding poses like child's pose or with props. It can be a very relaxing experience. So she was at kind of the rec center, and so she agreed that she would increase restorative yoga practices, a few times a week, and decrease the time spent doing power yoga. So this was kind of our agreement. So you'll see here that what I was trying to do in that intake was honoring her autonomy and giving her choice where I could while maintaining her safety. So recognizing that she had lost some weight and that it would be important for weight restoration to happen. You know, wanting to make sure she was, medically stable, but also not wanting to force an agenda or make her feel like she had no choice in the treatment planning, and really inviting her voice in as we made goals. And so that was kind of the end of the first appointment. Ongoing assessment and treatment included really externalizing the eating disorder voice. And so there were times where, and you may have this experience with someone with an eating disorder, where their whole affect can change, and you're no longer speaking to the individual, you're speaking to the eating disorder. The eating disorder has completely co-opted them, and they're angry that they are being challenged. And so there were times, and recognizing, I think I shared last week that I use a lot of interpersonal process, acknowledging that like there were times in session that like I felt like I was talking to the eating disorder. If there were ways that we could put, sit the eating disorder down on the couch next to her, we can come back to the eating disorder's concerns and worries about what we're talking about. What's happening for this individual? If this individual had voice separate from the eating disorder, what would this individual say to this suggestion, to how the week went with eating, to feeling safe without engaging in the behavior, and kind of creating space and session to acknowledge the eating disorder, but really spend time separating out the eating disorder voice from the individual. And it may be that there are times, depending on the how long or chronic the eating disorder behavior has been, that process of externalizing the eating disorder can take some time, because it can become so enmeshed with that person and the person's identity. And depending on the function of the behavior, a really important way to feel safe. And so it can be really scary to think about separating from the eating disorder. Yes, so the motivator for that initial treatment was to be able to stay on campus. And absolutely, there is a lot of fear in the being forced to let go of a coping strategy that works for them, and at least right in their mind. And so also having conversations about, if we were to acknowledge what the eating disorder has done and how it's served you. So maybe in this person's mind, it's kept them safe, kept them emotionally distant, it's kept them alone, which has felt safe. We can acknowledge that, but in other ways, how has it not served you? And so in this case, yes, it's kept you alone, but you're also someone who really seeks social connection and community, and that's really been interrupted the last few years. This person had some history of not healed fractures due to osteopenia, and so recognizing the impact, or starting to see kind of potentially the long-term health impact or ability to be physically active. And then holding, as much as she enjoyed being isolated, and we could acknowledge after a point that her eating disorder really liked being isolated, that she really wanted a healthy relationship, and it was really scary to think about what that looked like or felt like, since it hadn't been modeled to her, and she didn't know what that looked like, both romantically but also just with friendships. And also her, as I mentioned, there was some insight about how self-destructive the behavior was as well, in that it was recapitulating the pattern of rejection and violation, and honoring that she is, it's protecting her in her mind from feeling rejected or being violated from an external person again. But that all she's doing in the long run is really hurting herself and keeping herself further from the life that she wants to live. So I also shared last week that I use a lot of ACT in my work, and I find ACT to be really helpful from my theoretical orientation and clinical perspective with eating disorders, because the goal of ACT isn't to change someone's negative thoughts, right? It's more to increase psychological flexibility and do some values exploration and see kind of where that congruence or incongruence is. And so I, kind of like in eating disorder recovery, I saw a quote once that says, like addiction, I think there's a lot of perspective that recovery from an eating disorder is an ongoing, lifelong process, and that achieving recovery in an eating disorder is very much like, the thoughts and urges may never go away. They may always be present in the background, but that recovery is this idea that the individual has control over the radio station dial and volume. So, life undoubtedly will throw us all curveballs, and stressors happen, both good and bad. And so that someone can be in recovery and have an increase in thoughts or urges to engage in behavior. However, in recovery, they'll be able to be in control of the dial of the radio station. So they can change this channel, lower the volume, and choose healthier coping that isn't self-destructive or a short-term way to self-soothe or regulate emotions. And so just recognizing that some of that process is, the assessment of financial resources for healthy eating. Yes, I think, I think it's important to assess kind of the financial resources growing up and the impact on food security or options for food. And so I think it's important to also assess what's realistic and what's kind of what the financial resources are for healthy eating. Also recognizing that like brainstorming and collaborating with the individual about broadening the term of healthy eating. And so, like if it's canned, frozen vegetables or fruit, if that's, if there is a way to work that within the grocery budget, if there is a lot of eating out, kind of on the go fast food, due to occupation or just schedule, if there are options that are more healthy or well-rounded or providing a more balanced, just recognizing kind of how can macronutrients fit. I do have a list, so I like also keeping in mind kind of your own scope of practice. And so there is a list that I will share with clients that have a lot of dietitians that work with kind of suggestions about kind of broadening what healthy eating is kind of within a budget. If that would be helpful to share, I'm happy to share that handout. That includes dietitians and then also other mental health providers as well. but I think, yeah, recognizing the reality that food is really expensive and food costs keep going up. And unlike addiction to other substances like alcohol or other drugs, and while recovery from other substances is very difficult, has their own barriers, I'll often sit with clients where they may feel critical of themselves or frustrated with themselves because here is this quote unquote basic life thing, eating food, that they feel ill-equipped to be able to do to show themselves care. And then when they look to the outside world, there isn't a whole lot of modeling about what like a healthy non-disordered eating looks like. Because if you step out the office, there's, you're likely going to see or hear an ad about changing your body or eating a new trend diet or intermittent fasting or quarantine weight loss. We're inundated with messages so much it can sometimes be hard to recognize how much that's just kind of in our conscious. So I feel like I went off on a ramble there. Yeah, so I've sat with clients who, with this recovery, it can be an extra barrier is they can't avoid food. Someone who's recovering from alcohol, part of their safety plan and relapse prevention plan may be to avoid the bar, or, individuals who use and have a different kind of social events. Someone with in recovery from an eating disorder, their relapse prevention plan can't include, avoid food. It has to, it may include like responses to conversations that are triggering, or how to redirect conversation or use your voice to, set a boundary. And it may include even like not going home for Christmas to spend the holidays with family, because that's a really unhealthy environment for the individual in their eating disorder recovery. But they're likely going to be somewhere at dinner at the holidays and eating. And that can be a really stressful time, even in the healthiest of environments. And so just recognizing that, and, really being with the client in the hardness of that we have to learn to eat and take care of ourselves in this physiological, biological way to survive. And that's going to, that challenge will likely show up at different points kind of throughout treatment. So great question. Might it include avoiding certain triggering foods? So that's a really good question. It is common. So I have worked at higher level of care settings previously. And, it's common at a partial hospitalization or residential program. An individual might note 3 foods that they dislike that's unrelated to their eating disorder, and then 3 fear foods, with the idea that these fear foods are trigger foods, and that part of treatment is reintroducing fear foods into treatment to be able to manage and tolerate the anxiety, and to also challenge some of the perhaps distorted thoughts about what will happen if I eat this food. And then they will likely also be asked to eat the foods that they dislike a few times to see if it is related to their eating disorder and manage kind of the anxiety with that, or if it is just a dislike. And so recognizing that at higher level of care settings, you are working very closely with a dietitian and meal plan. There might be times, so part of treatment is reintroducing and kind of permission to eat all foods with the idea to decrease those strong cravings that can be a part of that binge restrict cycle. And there might be times where, depending on the environment and people there, that there are safer foods to eat that are more aligned with recovery and in long term will keep them on that recovery path. But generally, I'll talk to individuals about making sure that they are also eating fear foods. And so sometimes I've done that with, it can be really hard to do that alone. So it might be spending some time identifying, social supports who are supportive of their recovery, are not engaged in diet talk, who are willing to kind of eat a fear food with that individual. I have also eaten a donut in session with a client and sat with that person, and we've gone through some grounding and challenged some of the cognitive distortions that are coming up. The other thing that I think is an ongoing conversation with the client with a history of trauma is if we recognize that the eating disorder and there's a collaborative conversation, there's agreed upon understanding of how those behaviors are serving the individual. So it may even be like someone's keeping, a journal throughout the week of when they engage in the behavior and if they have a sense of what motivated that or how they felt afterwards. And so then you together can talk about, is this, can we understand this more as self-harming, self-destructive behavior, kind of recapitulating the pattern of rejection, violation, whatever the client may be feeling, using the client's own language. Or is this a way of keeping yourself safe? And do you find yourself engaging in eating disorder behaviors or having strong urges after certain interactions, after events or situations that you have to be in? Is your supervisor at work recapitulating patterns from family of origin that are toxic and triggering? And how, what does this do for the rest of your day? How do you then engage the rest of the day? And so getting an agreed upon understanding of the function of the behavior. I'm just believer that every behavior serves a purpose, and it's really hard to change the behavior unless that's acknowledged, while also recognizing that there are certain behaviors that are really dangerous. So if somebody comes in and is reporting that they're purging multiple times a day, I'm referring them to get blood work and to check their potassium and perhaps be at the hospital to get medically stabilized because I guess that's a concern that can feel very much like Russian roulette, the binge, like the purging, and that the risk for cardiac problems is just so high that as we think back to kind of those first reflection questions I shared with you, that is a presenting concern that always has me a little bit more on alert. And so making sure that somebody is medically stable to engage. So if someone is actively purging, I've made treatment contracts in the past that, I care about you and your well-being and your livelihood. You're medically stable and the purging needs to stop or decrease. And so what's realistic? How can we shore up support throughout the week? What can we do? How can we surf those urges, which is, similar to addiction addiction treatment to manage so you're not engaging in those behaviors. I have found in my experience that if I am expressing to someone who is, primarily engaging in purging behaviors, providing some psychoeducation about the risk of cardiac problems, the risk of cardiac heart attacks. It's not often that I've had someone come in purging and knowing the extent of the damage that could happen, and expressing the concern that can help with motivation to at least decrease the behavior. It's not going to go away overnight. It's not going to go to zero, but that does increase the motivation to decrease the behavior. And so it may be that as you're establishing safety and focusing on trauma, it's not uncommon for eating disorder behaviors to increase. And so having an ongoing conversation with the client each week about adjusting the dials. If somebody is leaving session and there was a really hard session, a lot was processed, examined, talked about openly, and they left session and had really strong urges to restrict or binge or purge or go exercise for 5 hours to numb out. I'll validate that and normalize that and just share that means that we need to make an adjustment so that when you do leave session, while you may have stronger, louder urges while we're doing more focused trauma work, we don't want it in such a way that you're not able to manage those urges and overall, with the goal of decreasing those behaviors, but also validating that we fall back to the ways that we have learned how to cope, even if they're unhealthy. So it's very much an ongoing assessment each week about kind of and increasing their understanding and awareness between the focused trauma work that's happening, and that may be establishing safety in their body, in their environment related to the trauma, while also how are we establishing safety in a way realistically that will also be slowly, perhaps decreasing some more of those disordered eating behavior. So I've worked with other individuals who may come in and report, I was really angry, with some dynamics at work that triggered some flashbacks, and I really wanted to go spend hours at the gym after work and numb out. And maybe they went to the gym and were able to realize that, and they were able to get off the treadmill in half the time. And so also really just celebrating any shift that person is doing in increasing their awareness and understanding of behavior, and recognizing and changing the behavior in a way that feels more sustainable and healthy in the long run, and not just in the short run. So also validating, right, that as I shared last week, that, some of the, I think DBT skills can be really helpful early on in establishing safety, both with trauma and with eating disorders, that engaging in grounding, creating a self-care box of activities that they can do when feeling distressed or dysregulated, won't provide the same relief or numbing out as severely restricting. And we know that on a neurobiological level, because severe restriction is going to decrease emotional processing because it's not needed for survival. So I'm going to pause because I've been talking for a very long time. And I just want to check in and see, we have time for questions, reflections, if there are pieces that I missed or clarification. Will stop sharing my screen.
I think your comments on the medical risks of binging, one of the things that was going through my mind while we were talking about this is how anorexia and purging primarily live, I know there's a lot of differences in there, but like primarily live in the DSM-5 in the mental health world. And then you've got overeating and obesity that primarily lives in the medical world. The risks of keeping those in separate places rather than understanding the adversity traumas that can drive both of those. And if the mental health world doesn't consider the medical impact, and if the medical world doesn't consider the mental health impact, how we're just the risks that are present there. It's just one of the things that was going through my head.
Yeah. I think too, recognizing how the medical world for some individuals can be very re-traumatizing, depending on language used by the provider, shaming that can occur without recognizing, again, right, the function of the behavior that may have led to the medical visit in the first place. And so I think it can, and like, I think on the flip side of that, the reality is it can be so hard to find providers who are specialized in working with eating disorders, who are specialized in working with just weight and eating behavior and concerns in a trauma-informed way. And I know for me as a clinician who really loves doing this work and cares about and believes in recovery, when trying to create an interdisciplinary team or make referrals, that can be a very helpless and isolating feeling of, I don't know what's going to happen at this appointment, and you need to go get your blood work done, or you need to go see the dentist because the history that you're reporting on purging is so concerning to me. And so I think providing some context about, what one might expect at the lab or at the dentist, and validating their experience and responses, and that can be something that you spend some time checking in about the next time you meet, if they don't have a good experience.